Hello, everyone, and welcome. My name is Sara Pesko. I'm the Senior Director of Product Management here at Inovalon for Real World Data, and I have with me Tasha and Becca, two other Senior Directors as well. And we are absolutely excited to be talking to you about data. Pretty much, healthcare has never had more data. Healthcare has never had more questions. This isn't a bad thing. It's totally natural. With more data comes great responsibility. And so we're here to talk about that a little bit more. Really, where we're at right now in the healthcare and healthcare data world is we're kind of on a journey. I have a little human, and she is currently learning her alphabet and currently learning words. When we think about data, previously it was like learning words. We knew cat, we knew hat, we knew bat. But now as we add in different types of data together and start to create a deeper understanding of not only just the longitudinal journey, but also the clinical depth, now we're actually starting to put together sentences. And those sentences are starting to become themes. And we're actually able to tell a story now. So what does this mean for the healthcare industry? How is this really changing for us? We're seeing that evolution in real time, and it's an incredibly exciting thing to see. Thinking about things like AI, analytics, and the increasing connectivity of data is uncovering not just the data points, but the relationships between the data points that have been hidden in plain sight before. So we're going to talk a little bit about some of these concepts today and start thinking about what we're seeing not only in the market here at Inovalon, but just in general. So what I'm going to ask this absolutely amazing panel of women is evolution of data. Are researchers asking different questions today than they were 5 years ago? Or are we asking the same things? How have what we're asking changed?
I love this question. So, I 10 years ago was a hospital epidemiologist, and I was actually doing primary research, chart extractions in the healthcare system. And a lot of the questions we were asking then are questions that we are now asking today utilizing real world data. And the reason why this is so exciting is back then you had people, everyday people, having to do manual abstractions from charts at a singular health system. So I was in one geography. I would maybe be able to do like 100 charts, like think of the bandwidth a singular person can do. And then also because we're people, we have bias, we also would have to have someone go in and audit those chart abstractions. And all of that would be months worth of work with small sample sizes in a singular geography. And we can now answer those same exact questions utilizing real world data where you have national coverage, you're able to have generalizability to those populations, and you're be able to have scale because you actually are able to take not just a singular health system but health systems across the whole United States and actually start doing those comparisons of even like a rural versus urban, academic versus an acute care. All of those things are now able to come into view, and you're able to deal with those resource constraints that were there previously by people like manually having to do these things. So I think some of it is just we have those same questions, but we're now able to answer them better and at a larger scale. And then also that's starting to create new questions because we're now seeing that there's the possibility to answer them.
Yeah, and similar to Tasha, I've also been in the real world data space for about 10 years. Prior to that, I was a registered nurse. I worked in nursing research and a little bit of time in insurance as well. And when I was doing nursing research, we would get data from the hospital system that I was working with on a CD to, load and the charts, the electronic medical record data, and also did some medical record abstraction where, we're reviewing kind of scans of charts and pulling out the necessary data points. And there's so much less friction now and so much more access to data. Even when I worked in insurance, again, over 10 years ago at this point, I had to be on site at the insurance company, hooked into my physical computer. I didn't have a laptop and the ability to look at data from home. And was working in software where I had to kind of every morning log in and rerun out some of my scripts and take a look at the updates that had happened overnight. And now there's just so much data available and it's linkable. And so I think we've kind of turned the perspective around where 10 years ago, it was really like from this data set we have access to, what questions can we ask? Whereas today it's really what questions do we want to ask and how do we pull together the right data set to support that question. So there's so much more that you can do, shifting the perspective around.
I think that those are really great points, and I love the actual experience. I'm laughing, Becca, because I as well have had to have CDs handed off of data too. And of course, for those of you listening at home or in the office or whatever platform you are listening on, join the chat. Feel free to sympathize. Maybe someone out there has had to use a floppy disk. I don't know. But also ask questions and participate, because we will read from the chat. So please, please, please talk to us, because this is interactive. But so we're hearing that the questions are changing, the questions are getting answered better, but also structured data is fantastic. But where are we starting to see that shift? We know structure doesn't answer everything. How are we starting to adjust to that in the market, especially in the world with AI?
Yeah, I think so much of the structured data that we have access to today was, created due to the billing process and what, fields fit into a billing form. And even on the EMR side, what variables are easily fit into standard categories, versus we know so much of the patient experience varies from person to person. And, there's so much rich context that doesn't fit into structured fields, just, by the nature of the diversity of patient experiences. Yeah, I kind of think of it as, back in nursing school, I think there was even a title of a course, the art and science of nursing. And it's there's all the scientific fields that are very measurable and standardized, but then so much of healthcare is still really the art and the difference, patients show up clinically looking different. They, how they react to treatments varies so much. So there's so much additional context that we can now take into account with AI, really, get our hands around what is predictive, which patients will react positively to a treatment, who are the best candidates for a clinical trial. Some of those questions become just so much easier to tackle.
Yeah, I think Becca pretty much covered it, but also just, that exact example I mentioned on the
Yep, I think we might have had a technical difficulty. I think this only happens to tech companies when something like this comes up. But we'll let Tasha's system reset a little bit. Becca, I love that you're pulling some of these things out, but also thinking about it, what was so difficult in the past about clinical notes to analyze? And how are we unlocking that? You talked about having to do chart review and having to look at all this information, but how are we actually now being able to extract that? Because I'm seeing in chat people asking which parts of the research process are benefiting from this today.
Yeah. When I think about medical record abstraction and how we've done it in the past, you're really a person reading through the notes and understanding what another person had written down. And you had to have the clinical knowledge to understand what the note was saying and to put the pieces together. And AI, it can learn so quickly. You can feed it, the textbooks of knowledge that you learn, in a healthcare, educational setting. And it can start with all of that knowledge to try and pull out the relevant, keywords and pieces that are popping up, and kind of draw them into a format that's more easily queryable. I mean, when I was looking at medical records, it was usually PDFs. So you're not even, able to highlight and say this is the relevant part. The software and the systems have just evolved so much.
I think that that's something that really we're starting to see on the real world data side too, is that with AI being available, it's almost like having a graduate assistant is kind of the way I think about it. And not to trigger anything, Becca, as you're completing your PhD, but it's like someone that can give you a little bit of the too long didn't read, or here's some of the interesting things that we're seeing, but not just the questions that I'm answering, but also being able to leverage it and start to see, here's the questions you might not have thought to even ask and what's going on. And so I think it's removing also a little bit some of the bias of, or it can potentially, when we're looking at a data set as well, which is incredibly exciting, as well as getting us to the questions a little bit sooner. So Tasha, thank you for coming back. I know I think you were about to give us such a good tidbit of information that that the system just couldn't handle it. So what I am going to say is the industry is kind of moving from what happened to why did it happen. Where are you starting to see that in some of the analytics projects that you're working on?
Yeah, so I have two things that I'm like so excited that only really clinical notes can answer. And one of them is first, like we've always looked at in claims data, treatment patterns. What are going on? Why is a patient taking a medication? Why, when are they switching? But you don't know why they're switching or what's going on with those decision making. And that can really only be found in clinical notes and that narrative of, between the doctor and the patient on what's going on. And so now we're able to tell, is this something an issue with like payer and coverage? Is it a cost issue where the patient, can't pay for even the copay? Is this an issue of symptomology? Are they having, bad events and symptoms? Are they hearing in the market or from other people or a different specialist of a drug of interest? So all of these things are things that can contextualize why a patient is taking a drug, switching a drug, non-adherent to a drug. If, we're seeing even contexts of patients, expanding out their one fill per month to 2 months because they can't afford it. All of those things you will never know by claims, but you can answer by a clinical note.
And Becca, I know that even the team has been starting to dig into some other things for the why. I know in the past when I've worked on the provider side of the house and thinking about specifically in surgery, there's so much that goes into surgery that's not just I've done orthopedics in the past, that is not just the joint replacement, but there's so many tools and methodologies, and those methodologies can impact care and outcomes. What are you seeing in the clinical notes that maybe we couldn't see before, even in the structured EHR data?
Yeah, Tasha and I have both been digging into our EHR data, specifically the surgical data and the procedural data. And there's a lot of rich information in there, pairing the clinical notes with the structured data together. We have really detailed time stamps in the data. So I've been looking at that for a number of use cases in terms of how long are surgical times for a surgery start to end, but also just for monitoring length of different types of procedures. So I've been looking into a variety of different procedures. In terms of the note, it can also add, exactly more detailed, not just what surgery was completed, but maybe what area of the body, the approach, the incision, how did it look at closure? What did the wound look like? So any kind of monitoring for infection, we're seeing a lot of detailed information in the notes on that as well. The vital signs as they were kind of going into surgery, leaving surgery, we can see that level of information. Yeah, I'm trying to think, what else am I missing, Tasha?
Okay, so this is near and dear to my heart because I used to do surgical audits. You can see everything in the note, which is really cool. You have the operative or note by the actual surgeon who's actually like doing everything. He's doing his narrative. You can see all of the tools they use during the surgery and all of the findings and especially complications of the surgery, which you cannot see at all in structured data or in claims data of, oh, I found purulence within the, colorectal cavity. Like, why is that purulence there? And what is going on? Is that going to impact the patient's length of stay? Does that change the medications they're giving during the surgery? And you can actually see that as well in there of, oh, well, now I need to do IV, like a different IV antibiotic during the surgery. And you can actually see the medication and what's going on and the timestamp of when that medication happened within the surgery as well. So not only do you get all this great information on what the tools are being done, the approach, but you also get all of that interesting information on what could be going on during that outpatient or inpatient surgery encounter as a whole, and why maybe a patient is going to have another outpatient visit that you wouldn't have expected, or why this patient is now going to have a very long length of stay in the hospital that you typically wouldn't have for this surgery.
I think, Tasha, you might have indirectly or even directly answered Whitney's question in chat, which is, what is the most untapped source of clinical insight in healthcare today? But just in case anybody wants to weigh in, any ads from the group?
Yeah, I think we've tackled a lot of it, all of the fun things that are within the like narrative of clinical notes. And then I know something that we've been talking about a lot at Inovalon is rare disease. And I think a lot of times, like especially in claims data, there is so much missing on the journey to diagnosis that you can also see within the clinical notes. You can see what are the diagnoses that the different physicians along that rare disease journey are thinking. Why are they sending them to specific specialists? Why are they ruling out other diagnoses? I think a lot of us have people in our lives that are experiencing rare diseases, or ourselves are experiencing rare diseases. I know myself, my mom has multiple sclerosis, and it took her over 4 years to get diagnosed. And she saw so many different specialties during that time. She got so many different preliminary diagnoses that they thought was going on before she actually ended up with that diagnosis and was able to actually get treatment for it. And so I think a lot of us have been in that state and know people in that state, or ourselves are in that state. And this is our opportunity to identify those patterns for patients and help close those gaps so that they can get the care they need earlier.
So what I'm really hearing is this more complete story is changing research and patient care. Becca, talk to us a little bit more about what you're seeing out there, where being able to fill in the why, the what's, and sometimes the multiple attempts it takes to get at a diagnosis. How is this changing research, and how are life science companies and academic facilities starting to think about this?
Yeah, I think this pairs nicely with some of the questions that are in the chat as well. The both kind of larger context and scope of data that we have access to, plus the AI technology, is just speeding up kind of everything throughout the cycle. So both, getting patients diagnosed more quickly, getting patients into clinical trials, identifying the right treatment, even getting drugs onto the market for the first time. I think we're just at the very beginning of seeing all of those kind of processes speed up. Even learning about research, I think they say from publication to a change in practice is something well over a decade historically, and all of that is beginning to shorten, because even on the research side, as you're kind of digging into the literature reviews, AI can help on kind of all of those processes. Just what is the current standard of care today? What is the latest that research is telling us? Clinicians are able to take in more information and aggregated information so much more quickly as well.
And also, even in the, what are we at? About 60% of all medical spending is on rare and difficult diseases. Being able to find the patients, target the patients, as you were saying, Tasha, there's so much of a pathway to even get to that rare diagnosis. With AI coming into play and being able to, what I would say is stitch together so many different data sets, that patient's story becomes a lot more clear, and you can say, oh, you know what, this person actually might be eligible. Should we get them onto this treatment, or should we get them into this research? And even further upstream, the more and more that I'm talking to the market and speaking with some of our fellow researchers, is that there are areas where they thought, this might not be a viable path for us to even go down and think about. But now that they can see or target, or the possibility of even looking at these rare diseases is a lot more possible, it's making them more inclined to try to tackle these, which is really then extending care and servicing the healthcare industry as a whole. So it's, I think we're seeing it all across the continuum, not just at, to your point, Becca, not just at, oh, how is this going for the outcomes, but how is it going for the research? And then how is it going when you're researching for your research coming on down the path?
Yeah, I think in the rare disease kind of space that Tasha was mentioning, the notes can have, details about symptoms and the patient's complaint, earlier, before they may even know what the diagnosis is, or for conditions that don't have a specific diagnosis code. AI can help pick up on what are the terms that patients are using to describe their illness before we even know what it is.
Mm-hmm.
Yeah, that's a really good point. I also like that you mentioned diseases without diagnosis codes, because there's a lot, even if they have a high level, I'm going to use sickle cell disease for an example. There's different types of sickle cell disease. There's different subtypes within there, and they do have ICD-10 coding. But if you look at the actual, how often patients are actually getting coded with those subtypes, it's very low. And so really you need that clinical note, you need that information from the EMR data to actually know what type of sickle cell disease the patient has, and therefore like what are the outcomes associated with that and the treatment that are used for that specific subtype. And that's just one example, but that exists across the spectrum from diseases. There's really a limitation with like using only billing created information to create those journeys, which is, claims it's great and it has a lot of strengths, but you really need more layers to that to really get at a clinical picture for a person.
I'm going to I'm going to go into chat and see. I have a question that's a little bit about, I'm going to say a little bit of a warning, and then we're going to go into a little bit of the blue sky after. So the first I see from Mark on here, how do you protect against introducing bias when training models to interpret the unstructured data? And I'll give a little bit of a lean in as a big old data nerd here. I think some of it's the data that you're using even to train it. What I've been hearing consistently, I'd say over the last 8 months from this surge of AI and everybody starting to go for this, is if you look at a data set that maybe has a very specific set of patients or isn't nationally representative, or maybe is biased only towards one plan, your data is starting the whole bias off. Not even how you're building the model yourself as a researcher, but the data is inherently biasing you. So I would say finding something that is nationally or internationally representative. I would say something that's looking across all different types of plans. Also, the more intricate patients that you can be able to bring into your set as well is going to allow you to not have the bias of just maybe going to one versus another. If I only went to and got data from A hospital or from B payer, then I'm only going to see the coding bias and the formulary bias of that payer. Or I'm only going to see the EMR logging and quality level bias that we might see in coding at the provider side, and that's going to feed into my model. So I would give some advice as look into the data that you're building your models off of and try to get the richest, most broadest data that you can have to be able to answer that question, to at the start give you a little bit of that extra edge as you're getting started building. But I'll open it up then to the other ladies on the call.
Sorry about that. I was going to say, that's exactly where my mind
went.
Yes. No, I completely agree, Sarah. That's like exactly where I jumped to as well. In my role at Inovalon, I spend a lot of time talking to people that are using our data about the data itself. And I think before, training models, really understanding the source of the data, what providers are contributing to the data. Is it academic medical centers? Is it community hospitals? Is this outpatient? Is this inpatient? What kind of ages, insurance coverages, really understanding the data before building on top of it to know what is well captured, where the bias might exist in the data itself, and being able, if there's certain gaps, how do we pair data sets together to kind of have the best data set as our groundwork before starting to build on top of.
Yeah, I think those are like really covers a lot of like the conversation, and the biostatistician within me always goes back to junk in, junk out, right? Like AI modeling is the exact same as when you're thinking of like your other statistical models that you're building. Like if you don't have the foundation of what is being trained in this model that's representative, that you can understand how it was built and why it was built and what is feeding into it, like that's going to bias your sample. And that's why we pride ourselves here at Inovalon on having primary source data, because we actually know what's going on. So that gives us a lot of confidence in the things that we're building.
Understanding the sources is so critical, and the closer you can be to source, the more information you can know. On that note, I know we're, I think, about 5 or 6 minutes out from here. I see so many people in the chat asking about future. I'm going to keep it a little bit more broad than some of these specific topics, but where do you see the future in the next 5 to 10 years? Where are these topics going? How are we seeing things being impacted?
Yeah, I think first, just like acceleration of these questions that we traditionally have not been able to answer, mostly because of resource constraints. A lot of these questions are things that required primary research before. They required actual surveys, patient provider surveys. They required chart extractions. They even required, as I just mentioned, I used to do surgical audits. They required primary collection. And a lot of these things can now be answered in real world data, which had that scale, but also just able to like reduce all those resource constraints behind answering those questions. So a lot of it is just, we're going to be able to expand our evidence generation. And even though like, and clinical trials are extremely important, gold standard for research for a reason, but they also are very structured and they don't showcase the real patient journey. As we already kind of talked about today, is, there's patients that maybe they're, stretching out their fills of drugs because of pricing. I like to pick on GLP-1s because, they're easy to pick on right now, but in clinical trials, it's a very structured environment. We know they're getting their nutrients. We know they're doing, certain exercises. We know they're being adherent. When you look at the real world landscape of what's going on with GLP-1s, we all know that that's not what's happening on a day-to-day basis usually. So I think right now it's just being able to really expand that evidence generation that we weren't able to have at a timely resource is kind of be that first constraint. And then the second thing we're going to all be able to do is expand upon that. What are the new questions that we get to ask?
Yeah, and I was going to say, I think also like the comfort in working with real world data and using real world evidence has only grown as more people have exposure to it and experience working with it. Kind of everything's coming together and converging at the same time. So real world data, where at some point people would have been doing projects for the first time, they're now, okay, I've used this data set before, I'm comfortable with it to be able to ask new questions. We're kind of building on that collective experience.
I feel like, not to go too much back to the original intro, but we were talking about kind of that cat in the hat level. Great storyline for a 2-year-old. But now with how we're able to connect data across different data sources, how we're able to link that data together and then create that patient narrative in more in depth, I think to me, it's going from Cat in the Hat to reading Harry Potter, to reading James Joyce, to reading all these different books. And from my perspective, I think that if you'll also be able to imagine more and tell a different story. And so I think this will really unlock researchers, not just from the time perspective, as we've talked about, but from the creativity perspective as well, because research, medicine, it is an art and it is a science. And so I think that this is actually going to allow us to open up a little bit more of the art side of that so that we can see more innovation. So we can see more innovation at greater scale and at lower cost, hopefully, and with quicker turnaround times. We've seen more and more drugs come to market faster without having to sacrifice the quality and the integrity of those clinical trials, because we've learned from the data in the past, because we've been able to do those amazing reviews where we understand what's going on. And as an economist, there's a concept called standing on shoulders. I think this just lets us get up on taller shoulders so we can look over and have greater insights from that side of the house. So we see this coming in to Rosina, be able to ask your question into real world evidence, into complementing clinical trials. Absolutely. Whether you're starting your clinical trial and trying to decide how you want to build your trial from research versus all the way to having, synthetic twin arms, or being able to have your final analysis with your outcomes research, I think that it's going to impact everywhere along the line. So on that note, thank you very much. If we didn't get to your question, we absolutely can follow up. If you have any questions, of course, feel free to reach out to us. Feel free to interact with Inovalon online as well. We would love to provide you with more information. As you know, we are all big data nerds here, so thank you very much for joining us. And if you want to nerd out with us a little bit too, follow us on our LinkedIn or contact us in our other methods that we will, I believe, have up at the end of the screen after today. Thank you so much for joining, and even more thank you to those who have participated. We love an interactive conversation. Happy Thursday.